view. I think there is only one way to diagnose melanocytic lesions, either clinically or dermatoscopically, histopathologically, good or malignant, benign or malignant, and I will show you why. So I assume you received red cards and green cards. Is this true? Yes. And red stands for malignant. Is this true? And green for benign. Is this true? Chappy, fine. So just you can use them now for. Now, what do you think clinically about this lesion? Red or green? Now, dermatoscopically, red or green? Red. Okay. So I only saw red cards. Yeah. What about this lesion? Red or green? Dermatoscopically, red or green? Red. Only red cards. Now, what about this lesion? Clinically? Green. Only green cards, dermatoscopically? This lesion, clinically? Green. Dermatoscopically, also green. So, you only had green cards and red cards. You were one red, but it's a green. It's a benign lesion, but the majority assumed it was a benign lesion. So there's always one or two, yeah, who say fire, but usually the majority will assume it's a benign lesion. So how much categories did you need for these easy lesions? Only two, melanoma or nevus. And there's another proof that only these categories are enough. You received only two cards, red and green. And they didn't give you a gray card, did they? No. So how many categories did you need? Only two cards. And in a vast majority of cases, we are so sure with our diagnosis that we do not need a gray zone. We can tell immediately by morphology. But what did you do when you made a diagnosis here? You predicted biology by morphology. Why? Because you didn't see if these patients had metastases or not. You didn't know that. You did not know the biologic outcome. But you assumed that the melanoma that looked like a melanoma is a melanoma because morphologically it looked like that. So you predicted biology from morphology. That's true. Pathologists are doing the same. They predict biology from morphology. And this is a lesion clinically, dermatoscopically, green or red? Red, of course, because it's asymmetric and multicolored. And this is what the dermatopathologist is seeing. He sees also an asymmetry. He also sees asymmetry of structure and color because melanin is also asymmetrically distributed. So he practically bases his diagnosis also on morphologic features. Dermatopathology. And also dermatopathology just uses morphologic features, asymmetry, circumscription, size, architecture, and cytologic features. So pathologists try the same. They try to predict biology from morphology. But the biologic fate of a melanocytic lesion realizes itself in the future. You need some time to have metastases. You do not see them when you see the patient, usually, because we diagnose melanoma so early that the patients usually do not have metastases when we diagnose them. So we have to predict their fate by morphology. What is the problem? Also, Gerardo said this already. Morphology is a continuum. For example, this lesion is absolutely benign, you're sure. This lesion is also more or less benign. This lesion could be malignant, and this lesion is obviously malignant. So what did you see? You saw a continuum, but this continuum was a morphologic continuum. And now, what did they do in the past? They assumed that this morphologic continuum is also a biologic continuum, and they called this the gray zone. Yeah? But if you would ask this lesion here in the middle, if you go back, if you would ask this lesion here to have a pointer somewhere, not anymore, yes. If you would ask this lesion here, what are you? Are you a melanoma or are you a nevus? The lesion would answer, I know what I am. Yeah? I'm a melanoma or a nevus, you don't know what I am. You see, biology usually knows, but we have a gray zone in our mind. And this is what we call the gray zone, and it's purely morphologic. Morphology is a continuum, but biology is not. Why? Biology is divided into good and benign. You can be dead or alive. There's nothing in the middle. You can be pregnant or you cannot be pregnant. There's nothing in the middle. You can be a cat or a dog. There's nothing in the middle. You see, the continuum is morphologically and not biologically. Now, this is the problem, because we're not dealing with biology, we're dealing with morphology. And those who speak about gray zones and atypia and dysplasia and uncertainty and samples and meltdowns and stumps and whatever, they always do the same mistakes. They confuse morphology with biology. They think because they predict biology, what they say is biology. And I will also talk about atypical dysplastic nevi and atypical Spitz tumor to show you where the problems are with that concept. What is atypical and dysplastic? And I think you comprehend it best when we start with clinically and dermatoscopic images, because you're clinicians and not dermatopathologists. But I can tell you the dermatopathologists are doing the same. Now, what is atypical or dysplastic? The question is, what do we mean when we say atypical or dysplastic? I show you a patient with multiple moles, and you say, which is the most atypical lesion? Now, I'll show you some here, this lesion here. Would you call this atypical? No, some, no, most no. Would you call this lesion here atypical? No, no. Would you call this lesion here atypical? No, some say yes, some say no. Yeah? Would you call this lesion here atypical? Yes, 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 yes. So some of you, or most of you, would call this lesion atypical. Which one is the most atypical? So most of you decided that this lesion is the most atypical lesion. Everybody agrees on that? Now I rephrase the question. Which one is the most likely to be a melanoma? Which one? Again, you will pick this one. Agree? So when you say atypical, what do? You express your diagnostic uncertainty. Yeah? Although the lesion knows exactly what it is, you don't know what it is. So when we say atypical or dysplastic, we do nothing else to express our diagnostic uncertainty. So this is what is written here. Now, when we call this atypical nevus, it means we can never confuse it with a melanoma. And when we call this lesion dysplastic or atypical, we call it atypical or dysplastic because it might be that this is a melanoma and we make a mistake. And we call this atypical or dysplastic because it might be a melanoma. And we call this lesion atypical or dysplastic because it might be a melanoma. And when we decide to excise atypical or dysplastic lesion, we do not excise it because it may become a melanoma. No, because we excise it because the chances are that this lesion actually is a melanoma. Yeah? This is true. So we call these lesions atypical nevi because the diagnosis is uncertain and not the future is uncertain. But pathologists, by the way, are doing the same. They would call this lesion, would they call it dysplastic? No, you would not call this lesion dysplastic. I
never use the term dysplastic.
Oh, I'm sorry.
You know. But
is there any pathologist there?
If using the criteria proposed by the dysplastic colleagues, this is not a dysplastic nevus because it's too thick. It has the silhouette of una nevus, let's say.
So he would not call it dysplastic. Well, fine. Why? Because he would never confuse it with a melanoma. Pathologists would not call this lesion dysplastic because it looks like a nevus and they cannot confuse it with a melanoma. Now, what about this lesion here? Some pathologists would call this lesion mildly dysplastic. You agree? Mildly dysplastic? Because they're sure it's a nevus, but some melanomas may in parts look like that. Now, pathologists would call this lesion mildly dysplastic. Now, this lesion, what about this lesion? I know many pathologists who would call this lesion here with the single cells and some junctional nests, they would call this lesion here severely dysplastic, and they call it severely dysplastic because they may confuse it with a melanoma.